Hello.
Hello, Mieke. How are you?
Fine, and you?
Fine. Great. Great to see you.
Okay, are we ready to start?
Yes. Let's start again.
Okay. Okay. It's my great honor to invite Dr. Lee Rogers, head of the podiatry department at San Antonio in Texas, and he's going to be talking to us about their approach to the acute diabetic foot. The floor is yours.
Thank you so much. Happy
Welcome,
to be
Lee.
here. Thank you. Yes, I like the music at the beginning. We're rocking it at the Rockefeller. So, I'm the chief of podiatry at the University of Texas. Also, the immediate past president of the American Board of Podiatric Medicine, and I'm the associate editor of the Journal of the American Podiatric Medical Association. Don't say anything, Cynthia, about the length of time it takes to get published. She already gave me an earful. So, I want to ask you a question. What makes us human? So, it's not that we're sitting here in a classroom with our oversized cranium listening to a lecture. The defining characteristic of a human being is actually bipedalism, walking on 2 feet. So when I'm working on my patients in San Antonio, and there's something innate about their understanding of all of a sudden losing a limb and not being able to walk again, and they feel less than human after that. So when I'm working on my patients, and I understand now when a patient tells me, "Doctor, I'd rather die than to lose my leg." It happens to me all the time. And so what we do as podiatrists when we help people to heal their wounds and to keep their legs, we're actually helping people to remain human, or their feeling, their interpretation of being a human. So if you think about the evolution of humans, and think about this through the lens of how humans have died. So 50,000 years ago, we died mostly of disaster. So we got eaten by a saber-toothed tiger, you fell off a cliff, your cave wife beat you with a club because you didn't come home on time with dinner. So you died of disaster. But for about 50,000 years, the most common way that humans died were diseases. And we're talking about infectious diseases, things like the plague or other bacteria. Now, we have a little blip in the radar here with a virus, COVID-19, but it was 2019 that it was the first year in human history where humans died of decay, of chronic diseases. More humans died of chronic diseases than of infectious diseases. And again, aside from 2019 and a couple of years, which I think will just be a small blip in the radar, we're going to go back to having to treat the pandemic that existed before COVID-19, which is a pandemic of diabetes and diabetic foot diseases. And so we talk a lot about what it takes to prevent amputations in diabetes, and I'll show you some data, some collated data that really points to the fact that it's about having a team more than it is about anything else. It's not about one person. It's about creating a team around you that can work to prevent amputations in diabetes. So the first that this was really discussed, at least in America, was by a doctor who was one of the first endocrinologists. We're talking 1925, back when the field of endocrinology was just getting started. And his name is Elliot Joslin. He started the Joslin Diabetes Center at Harvard. And so he wrote in the journal that I'm now the associate editor of, which back then it was not called JAPMA, we call it JAPMA in the United States, Journal of the American Podiatric Medical Association. Back then, you might laugh, because we do, it used to be called the Journal of the National Association of Chiropodists and Pedic Items. So that's what it was called in 1925. And he wrote about creating a team to prevent amputations in diabetes. He already noticed this in 1925. He said that because when you got diabetes, before 1922-ish, there was no insulin. When you got diabetes, you died. That was what happened to you. After 1922, they discovered essentially pig insulin, and so it prolonged people's lives now, because you didn't die of diabetes anymore. You died of complications of diabetes. And so he said, insulin has introduced a new era in the treatment of the diabetic, but insulin will not cure gangrene, and in an indirect way may unfortunately promote it. Fully half of the diabetic deaths in the larger Boston hospitals are referable to the feet. Lesions in the diabetic feet belong in the province of surgeons, and he was not a surgeon. Leland McKittrick was a surgeon. He was one of the early surgeons that somewhat specialized in vascular disease. And he wrote also, insulin has placed a new responsibility upon the surgeon. In former years, the inability to protect the diabetic from serious medical complications made operation inadvisable, except in the more urgent cases. Today, insulin affords this protection, and surgical complications have replaced coma in importance, so that the surgeon is faced with the care of a group of cases requiring special consideration. So looking at there's actually many names for colloquial names that we put together for teams in the diabetic foot. David Armstrong and I created the toe and flow team. Really, David did. I wrote the paper, but he told me what to call it. The toe and flow team. And it's, but you look at all of these articles that have been published, and the pointer doesn't show up very well here, but this line in the middle is the line of no effect. These are all the articles that have been published about teams and whether or not they have an effect on amputations or not, right? So if they're on the left side of the line, they favor the team in preventing an amputation. If it's on the right side of the line, it favors no team. So what you see is that pretty much all of these studies, if you look at the diamond here, they're all on the left side of the no effect line. But also the standard deviation, which is, this is a forest plot, is what we call this. The standard deviation in many of these doesn't even cross the no effect line. So it's pretty robust data that shows that really just setting up your team to work and prevent amputations is going to have one of the biggest effects. So I want to just give a couple of minutes on a brief history of podiatry in America for those of you that are unfamiliar. Roughly 1895 is when the first licensing laws were started in the United States for podiatrists in New York. And the journal that I'm now the associate editor of, started in 1907. The first schools opened in 1911. But there were a series of 4 schools that opened between 1911 and 1916 in the United States. And then the Council on Podiatric Medical Education was founded in 1918. The boards, I was president of the American Board of Podiatric Medicine. They were founded in 1975 and 1978. I was born in 78, so that's when the board was founded. That's great. I get to celebrate our 50th anniversary together. The first DPM school that was fully integrated into a medical school started in 1980. And then the residency program, so we have to do residency after podiatry school. They were first standardized to include both medicine and surgery in 2004. and in 2011, so this isn't even that long ago, 2011 was when all residencies in the United States were standardized to 3 years. So podiatrists do undergraduate education, so they get their bachelor's degree in pre-medicine or chemistry or biology. Then they do 4 years of podiatry school, and then 3 years of residency. So this is essentially how the timeline of a podiatrist works. You get your high school diploma, you're 18 years old, you get your pre-medical education. This is over 4 years. You take a test to get into medical school called the MCAT test. Then you get your bachelor's degree. Then you go through podiatry school for these 4 years. You have to take 2 tests here and here, the American Podiatric Medical Licensing Exam, and then you graduate. Now you have your DPM degree. Then you do your residency training. This area right here, you're in supervised practice. And then afterwards, you finish and you get your certificate from you're finishing your residency. Now you're in independent practice. And then you become eligible to sit for board examinations over the next 8 years, and then it expires at that point, but you're still able to practice. So let me talk about where I come from, University of Texas Health Science Center in San Antonio. This is a large institution. It's actually one of the largest hospitals in the country. We're now the 3rd largest hospital in the country. And this is in an area in the south of Texas where the rate of diabetes is the prevalence is much higher than the rest of the country. This is due to the impact of Mexican Americans and also the American culture, our diet, which we gladly export all over the world. I saw McDonald's right down the street. So, if you ever want to know how America's going to defeat the world, we're just going to export McDonald's everywhere, and nobody will be able to fight in any wars. So there we go. So we have 230. We have a history of 230 residents that have graduated from our program. 115 still practice in Texas. We've graduated 40 fellows, and we've had over 1,000 students that have come through the program. The research here, it's a lot of you can see. This is UT where we are, and this is a scientometric analysis of all diabetic foot research over 70 years. And UT's roughly here, about number 20 in the world or so, but all of the people that graduated from UT, they're here, and then some people are here, University of Arizona, that's David Armstrong. And so you can see that the impact that UT has had across the research program is very large. Probably most famous for its wound classification. The UT wound classification is a grade and a stage. This was the first to do this. If you know the older wound classifications, that would be like Wagner. The Wagner classification was really a mix of both of those. So it didn't make a lot of sense to some of the early people that were at UT, because Wagner, you had 1, 2, 3. Those all really dealt with mostly the depth of the wound. 3, you could argue, also included osteomyelitis, which would be infection. Then 4 and 5 were both vascular complications that involved gangrene. So instead, what David Armstrong, Larry Lavery, and Larry Harkless did was they said, well, let's break this down into depth and stage. Well, this is stage and grade. So depth and complications. So we have 0 is a wound that's just healed or pre-ulcerative. 1 is a superficial wound not involving tendon, capsule, or bone. 2 is a wound that penetrates to tendon or capsule. 3 is a wound that penetrates to bone or joint. Now, A is uninfected, not ischemic. B is infected only. C is ischemic only. These are off a little bit, sorry. D should be down here. D is infected and ischemic. So what you can see is, as the wound becomes deeper or more complicated, this is the risk of amputation. The risk of amputation increases. So it makes sense that we would use a model like this instead of the Wagner model, which is just linear. So the UT approach, we deal with really complicated patients, many patients that are sick enough that they're dying when they show up in the hospital. We just had a death on service maybe 3 or 4 weeks ago, somebody that was transferred from another hospital with sepsis from a diabetic foot infection. As they came in the front door, their blood pressure was already 80 systolic, go straight up to the operating room, died in the operating room from a diabetic foot infection. So this is what we deal with in Texas and as a podiatry service. So we have our own service, we admit our own patients, we have an entire floor of the hospital. And so our approach is infection control first. This is a surgical and a medical approach. So do good source control, that's what we call it, remove the source of the infection surgically, and focus on culture-directed antibiotics. Then, right immediately after, ensure adequate perfusion. And this is done with our vascular surgery colleagues. And then we focus on, now we have a wound that's not infected anymore, it's perfused, but it's bigger because we made it big by doing source control. So now we have to figure out how to close it. And we close it with sometimes surgical techniques, sometimes they go home with a wound vac and they fill in, and then maybe we use different grafts or tissues as they're in the clinic. But we have to think, what are we going to do to close it? We manage the deformity. So if there's a deformity that's causing the wound in the beginning, that didn't change. We have to fix that deformity. We offload, and then we think whether we're going to surgically close this wound or use cellular and tissue-based products. Then we navigate the social determinants of health. I don't know if that's a term that you use, but where you have to think about where the patient is in their current situation and whether, I mean, everything from their home environment to their job, whether they have insurance, their socioeconomic status, their race, and get everything involved to try to make them understand how to be more adherent to recommendations. I don't have a timer. Mika, how much time do I have left? 5 to 7 minutes? Okay. Okay. So let's just go through a few lessons, things that we've learned is at UT, and these are actual patients we've treated, most of these just over the past year or so. But one, adequate debridement is paramount. So we have this patient that comes in already, you can see he's already visited podiatry at least once, right there. And so he comes in now, and this is, when I look at this, I say, okay, this is mostly ischemic, but patients that have ischemia they also don't mount a robust response to infection. And it's oftentimes after you revascularize them that the infection kind of blows up. But we have to remove all of this necrotic tissue, and just removing a little bit of the tissue is not good enough. You have to remove everything and get the edges that are with a wide enough margin that there is not that you're making sure that you're leaving only healthy tissue behind. We know this classic study on debridement found that the more frequently you debride your wounds, the faster that they heal. Doesn't really make a lot of sense to patients, but it should hopefully make sense to you. You're removing fibrosis, you're removing the senescent cells, the cells that are aging and they can't divide anymore. So you can see right here, this is a study of 313,000 wounds. Wounds that were debrided less than 1 week, dark blue, greater than 2 week intervals. This is light color. So you see the dark colors are all shunted here. They healed a lot faster in time than the lighter colors. So this is the debridement. You know, you remove all of that tissue, put a wound vac on, which we use a lot of negative pressure in order to temporize the wound so that it doesn't get worse over that period of time. And then we move on to tissue. This is a particular type of tissue that we use sometimes made out of cow tendon and shark cartilage. And then we plan for how we're going to get this closed with a skin graft many times in these cases, because this is a patient that's on the top of their foot. We get a lot of patients with marginal perfusion. Not only is this patient marginally perfused, but look at their hemoglobin. Hemoglobin's 6.5. Normal, this is in grams. Normal for us is for a woman probably somewhere between 10 and 12. But so even if she had great flow, she's still got poor oxygenation because her hemoglobin is so low. So, and she's got no non-palpable pulses. but she wasn't a bypass candidate. And so she had angiography. She has one vessel only getting to her foot. So instead, most people said, oh, let's just amputate her leg. So we put her in hyperbaric oxygen. We did an open TMA, culture and sensitivity of the bone. We did hyperbarics and wait for the tissue to improve. We revised and closed. Even after revision and closure, we still had a large wound that was left open. We used fish grafting, and now it's granular and ready for a split thickness skin graft. Here's a split thickness skin graft, came from her thigh. This is after fish grafting. Here we go here, and then she looks like this. This took 110 days. Now that's a long time, but this is in somebody that had no other option but amputation at that point. Here's another one. Again, remove all infections. So we're going to remove everything here. This smelled bad. You can see that their infection is traveling up here. So we have to go to the OR immediately and remove all the tissue that's infected. And now, this is a non-functional foot. So we're not going to leave 3 toes for them to walk on and heal. We save this tissue because maybe I'll use it to close some other tissue with. Sometimes we take the bones out of the toes and we use the toes to skin themselves to close. And so this patient had an angioplasty, but I can already see the margins are getting dark. So we use, this is SPY angiography with indocyanine green dye that we inject, and we can see the dye in the camera. So I can already see this tissue right here is not going to survive. There's no blood getting here at all. And so the debridement has to be a lot wider. So we remove the rest of the toes, get a good plantar skin here. So we leave only the plantar skin, and we have the remaining tissue that's all gone here. Use fish grafting, vac, and then skin graft. Also think about pressure. You can see here, anytime you see an ulcer on a hallux, especially distal or off the medial side of the hallux, you should always be looking for hallux limitus. It's almost always related to the limited joint mobility of the first metatarsal phalangeal joint. You can fix this either externally or internally. Externally with orthotics, or internally with a Keller arthroplasty. So we remove the proximal third of the proximal phalanx, and you can see here's before removal, here's in surgery after removal. Already have a lot of improved joint motion there, and it's amazing that many times the wound heals before the sutures even are removed. So again, another lesson, and we see this all the time, avoid prolonged treatment if salvage isn't possible. If this is a life-threatening or ascending infection, we're going to move to a major amputation. If there's non-reconstructible ischemia, in most cases, we'll go with a major amputation. Non-functional foot, with the destruction of the weight-bearing soft tissue, you saw most of the cases that we had, these had good weight-bearing soft tissue, good skin coverage on the plantar surface. We don't use a lot of grafts on the plantar surface. They don't heal well. There's too much shearing forces, so they're not very long-standing. And then if the patient is non-ambulatory already or has limited life expectancy, it doesn't make sense to go through heroic efforts to save the limb. Here's the last thing, as the last lesson. Sometimes you have to be inventive. This is a case that we didn't know what to do at first about this. This lady came in after she has total calcaneal osteomyelitis. She has diabetes, but no ulcers. She had a motor vehicle accident, had a calcaneal fracture, had the hardware got infected, and now the entire calcaneus is infected. And it was infected with MRSA and Candida, so both a yeast and a bacteria. So I took her to the operating room, removed the calcaneus completely, and put her in an external fixator, let the tissue cool down, put a filler in there just to hold the soft tissue so it didn't contract too much. And then we said, well, what can we do? So this is the first one done for an infection in the world. We had a 3D titanium implant made of her calcaneus that was based on her contralateral foot. Took a CT scan of her other foot, reversed the image, and printed a 3D calcaneus made out of titanium and implanted that with her. And now she's actually ambulating, and I just saw her maybe 2 weeks ago, got video of her walking back and forth in the clinic, and this avoided a major amputation in her. So I want to leave you with a thank you and also an invitation. We are always welcoming in Texas. We're happy to have people from all over the world that come and spend time with us. Some people spend just a few days. Other people spend a month. We also have research associates that stay and this has to be approved by the university, but we have research associates that stay for 1 to 2 years with us and help and work on research. So anyway, thank you very much, and we hope to see you in Texas.
Thank you, Lee. I'll take you up on that. I'll take you up on that invitation. Are there any questions for Dr. Rogers? Yes?
Hello, I just wanted to know what kind of orthotic devices or tools you use to offload the wounds.
Wounds, we're mostly using total contact cast. And we find that to be what we call the gold standard, or it's the best practice. Total contact cast, you may know the history of it, it wasn't really invented by Paul Brand, but it was discovered by Paul Brand in Bangladesh, and he started using it in India. Came back to the United States at the Leprosarium in Carville, Louisiana, and Larry Harkless, who was the chief of podiatry at UT a few before me, he went and learned how to do it. And so the first total contact casts in diabetes were used at UT, and so that's been a major part of the program since then. Now, offloading after the wound heals, we use a combination of either custom molded inserts, custom molded shoes, a lot of Charcot foot, so we do a lot of Crow devices, and so it's really a team effort in order to get that done. I learned so much from a lot of other places I go to. I was just in Ghent visiting Mika, and I saw a lot of the cut cam devices and things like that. These are not things that we're using, and we'd like to. That's why I even do these trips. So I go learn new things and bring it back. But those are things I think could be an improvement.
Do we have any questions from this side? Looks like we're set here.
Okay. Thank you, Dr. Lee.
So now I would like to introduce the next speaker, who is a great supporter of Empode. This is Professor Chris Nestor from Keele University, who will be talking about behavioral biomechanics, wearable technologies for diabetes pressure monitoring, and ulcer prevention. Great.
Is that mine? Yeah. Thank you. Thank you for your kind introduction, Alfred. This is a new format, so let's see how we go. I wasn't sure quite the direction of Lee's presentation, but I was really pleased that he gave the kind of history, and I think the trajectory of how diabetes impacts foot health, and illustrates quite nicely that it's an evolving problem. And I guess in my presentation, what I'd like to do is to stretch the ideas even further into a slightly different set of language, slightly different way of thinking about things. And I'm using this phrase, behavioral biomechanics, which you won't really hear talked about. But the whole idea is to challenge the fact that we've spent a lot of time doing things the same way. And if you want to get a different outcome for people, sometimes you have to think differently and do different things, which is precisely that trajectory that Lee was introducing to us. So I'm going to talk about behavioral biomechanics, and particularly about wearable technologies that measure foot pressure, and that we can use to support behavior-based changes in foot biomechanics. Okay, let's see how this goes. So I'm not going to do a detailed background on the risk factors associated with foot ulceration and diabetes. You will be very well aware of that. That's okay? I can improvise. There you go. So there's all the usual risk factors, foot shape, the tissue quality and properties on the plantar surface, the neuropathy and poor vascular status, of course. And then there are a series of, if you like, increasingly extrinsic factors about actually how and where do we load the foot during what physical activities, the duration of the activities that we choose to participate in. Kevin talked earlier about the fact that we are very comfortable and confident talking about compressive pressures under the foot. We know a lot less about shear pressures. We are doing some research to develop measurement systems and develop data on plantar shear pressures, but it's still something that's largely in its infancy. And then in the last category, we've got things which are genuinely extrinsic. There are footwear choices, our orthotic choices, and the kind of physical constraints we put on our feet. So these are the very sort of traditional background risk factors, if you like. And we have some really clear guidance that's evidence-based about what to do to modify some of the most important risk factors. And at the heart of the modification of risk factors is plantar pressure. And so this is just a summary of the work from the International Working Group on the Diabetic Foot. They do a really rigorous job of synthesizing the evidence and making recommendations. And their recommendation is, this is one of a number of recommendations, in a person with diabetes who has a healed plantar ulcer, prescribed therapeutic footwear that has a demonstrated plantar pressure relieving effect. And that's the guidelines at the moment. And what they mean by demonstrated pressure relieving effect is something around 30% pressure reduction or getting the plantar pressure below 200 kilopascals. And it's taken research a long time to get to those kind of hard facts and hard figures. And even now, they're not wonderfully evidence-based. They're guidelines, but they're the best that we kind of have. So we know we should be reducing pressure. That's really clear. Alongside the kind of minutiae of podiatry practice, there are some wider trends in health policy that I think are really relevant, that we need to blend together with our professional practice. This has got a very much a UK context, but it's not specific to the UK. So reference from the NHS long-term plan at the top talks about the need to encourage people to manage their own long-term conditions and talks about shifting care away from clinical centres and into the home and very much around self-care and self-management. Alongside that, there's the inevitable drive to try and digitize care or make care more digitally based. And so there's a digital health context as well. And so there's a neat connection between supporting self-care and self-management and using digital solutions to try and achieve that, because digital is in our lives and so pervasive in all that we do. So the question for me was, how do we blend something like pressure relief and something like self-management and digital health? So let's just return and have a summary of what you might call the load factors that lead to ulceration. And the ones that are on the screen are the ones you're very familiar with and we talk a lot about. Plantar pressure, peak pressure, pressure time integral. We talked a little bit about shear pressure, as Kevin mentioned earlier, tissue properties and footwear and orthotic choices. Those are all the usual candidates, all the usual suspects. I want to introduce the idea that we are missing many opportunities to broaden the conversation away from those very traditional concepts towards things like looking at the number of steps that people take, talking about the speed of walking, because we know that plantar pressure is very responsive to changes in walking speed, thinking about the surfaces we walk on, thinking about the duration and the nature of the continuous walking that we do. And if you think of walking as an episode of potentially injuring the diabetic foot, what you're talking about is a dose of injury and how long that dose lasts. And one of the other factors is the duration of time in between bouts of walking. And if you think about going to the gym and exercising your muscles, you would readily think about giving your muscles time to recover. But we never talk about giving the foot and the plantar surface time to recover. So there's a relationship between the bouts of loading and the bouts of activity, that we expose our feet to, and the bouts of recovery that we also need to build into people's care plans. And then there's the nature and the number of non-walking activities. We're a little bit focused, I think, over-focused on walking. If you want to look at, you get lower pressures when I'm standing here, but like most people, I'm leaning largely on one leg, but I've got constant compressive forces on my feet. So the pressures are lower, but they're constant, and that means there's no blood able to enter the capillaries and the plantar sole of my left foot right now. So there's no blood supply there, and that ultimately has a consequence. So it's not just about walking, it's about other activities. And then we can think about the accumulative effect of physical activity over several days. So for me, those are missed opportunities. So I want you to invite you to think a little bit differently for a moment. What if the biggest determinants of foot pressure, and therefore ulceration risk, were the decisions that we made about our physical activities rather than foot type and foot deformity? We spend a lot of time talking about pes cavus, this foot deformity, this joint range of motion. What if the decisions we made around physical activity were more influential, were more powerful than the intrinsic factors? Because we know that different choices would lead to different plantar pressure patterns and therefore different risk of ulceration. What if different decisions that people made are more effective at reducing pressure than orthotics? When the guidelines recommend 30% pressure reduction, that is a lot of pressure to reduce. That pressure's got to go somewhere. It's a lot to achieve. Most orthotics and footwear choices, 10, 15, 20%. 30% is an enormous pressure relief. So maybe making different decisions and different physical activities would change the pressure and the risk of ulceration more than orthotics. And if we had evidence of that, or we thought like that, it brings into our professional practice the idea that one of the most powerful things we could do for patients is to support them make different decisions and change their behaviors about how they treat their feet through their physical activity profiles. So could podiatrists become behavior change specialists and not just dispensers of physical devices? So this is, for me, and certainly in the UK, there's a conversation going on about how we evolve the workforce to respond to the changing need of the population. And as we want to do more self-management, every professional a person meets needs to be in a position to have a good quality conversation about how that person can improve their own management of their care. So behavior change definitely comes into the lens. Is there any evidence that making different decisions and changing your behavior would reduce pressure and reduce ulcers? And when you look at it through that lens, there is one standout piece of work. So this is from Seco Bus, who leads a very productive research group in the Netherlands. It's already 10 years old, this piece of work. They had 117 people who'd previously had an ulceration, and they put them into two groups. One got usual care, the other group got improved footwear. And the definition of improved footwear is reducing pressure by 20%. And when they looked at the entirety of their group, you could see that actually 38% of people in the improved footwear group and 44% of people in the usual care group had a re-ulceration. And there wasn't actually any difference between those two groups. But when they looked at people who had worn their footwear more than other people, in other words, they had high adherence levels, then you saw a very significant reduction in the number of people who had re-ulceration. And the difference here is not orthotics, it's not footwear. The difference is behavior and the decisions that people made. So footwear and orthotics can matter, but behavior also matters. Behaviors are about decisions people make. Decisions are about the choices people feel they have and that we present to them. So this is where I began to think about choices, decisions, and behaviors relating to plantar pressure, and therefore the idea of behavioral biomechanics. So if that behavior is really important, the question is, how do we influence people's decisions and ultimately their behavior? What if we told people about their plantar pressure, and not that it's high, but we interacted with them and provided information on a daily, perhaps, maybe weekly basis about their plantar pressure, or how their pressures went up and down with the different activities they do. Maybe they live in a single floor and they never experience stairs. That means that when they do go to a building where there will be stairs, their pressures will probably go up quite significantly. Maybe there's something they have to do in the week about shopping or visiting somebody that really increases their step count and therefore their accumulative plantar pressure during the week. What if we gave them that information? Would they make different decisions? Would they change their behavior towards their feet? If we gave them that information, people would then be in a position to make the decisions they want to make, and ideally, we would say, make different ones and reduce plantar pressure. And here, I think, is a window where we can connect the idea of self-management and behavior with plantar pressure. What you need to begin to achieve that is a means of measuring pressure and feeding that back to people. And thankfully, when I started my career 25 years ago, the challenge was always, how do you measure these things? We have no problems measuring things these days. We have problems with what does the data mean and how do we apply it. So this is one system called ORPIX. It's an insole system that you have a little app and it shows you pressure data. There's a sock system called Sensoria. But once you've got this data, it leaves us with lots of questions. The first is, they don't measure a lot of pressure or necessarily in the right areas. So we don't know whether they're giving the right kind of pressure information. They only measure compressive pressure, not shear, and we don't know whether that's important. What do you do with all that data? Do you give people peak plantar pressure data from every step they take, or an average of a day, an average of a week? Or do you just give them a traffic light system that says red light for stop when something's too high? So there's unanswered questions about what data we should be using. And ultimately, would people change them? Would they make different decisions and change their behavior? So that, for us, set two new research priorities. And the first one is to look at how we can measure pressure and shear pressure differently. And we're doing some of that. I'm not going to talk about that today. But the second one I am going to talk about, which is to try and research how people make decisions around their behavior, their physical activity, so that we can begin to interfere, influence, intervene with those decisions in order to reduce pressure, in order to reduce risk of plantar ulceration. So it's thinking about behavior interventions alongside physical devices, footwear and orthotic interventions. All of this work is predicated on a trial that was published by someone who at the time I didn't know, but I now thankfully work alongside, Professor Neil Reeves at Manchester Metropolitan University. And he did what I think is a really important piece of work. He took the system you can see on the right-hand side, which is a pressure measuring insole system. It provided very simple feedback to people on something at the time that was similar to an Apple Watch. This was kind of 2017, 2018. So a patient would get an alert on a watch that said, pressure's too high, move your feet, adjust your posture, change something. Just be a very simple alert like that. And he had two groups of people. One group was the control group, and the other had this information fed back to them. And the question was, did the people who had the information fed back to them, did they have less ulcers ultimately? And the window over which they measured that was 18 months. So what's really interesting is at the top you can see that in the group there were 10 ulcers in 6 patients in the control group and 4 ulcers from 4 patients in the group that were wearing the pressure monitoring system. So in principle, a 71% reduction. What's particularly interesting is when they reanalyzed the results, focusing on people who used the system more in terms of hours per day, they actually got an 86% reduction in the risk of ulceration. So the behavior is adding an extra 15% of benefit. The device is exactly the same, it's being operated the same sort of way, but the interaction between the person and the device is different, and that's generating the reduction in ulceration risk. So it's really driving us towards, well, let's get those 71%. Why doesn't everybody use it more? Can't we improve the interaction between the wearer and the information that they're getting about their foot pressure in order for more people to change their decisions and change their behavior? So how do we influence this decision making? When Neil published that work, I'd already had a couple of conversations with him because I just thought this was really interesting work. And we've since then managed to get some funding for a project which one of my ex-PhD students, Sue Skidmore, is now employed on at Keele University, and Neil's got his team in Steve and Olivia at Manchester Metropolitan University. The aim of this project is to develop a behaviour intervention. So a tool, a process that supports people to respond to the plantar pressure data they get from a wearable system in ways that enables them to make better quality decisions and reduce their plantar pressure. So we're designing a behavioural intervention, nothing physical about orthotics, footwear, just an intervention to change behaviour. And we're doing that in 2 phases. The first phase is involving 30 people, and as of yesterday we had 24 enrolled. And they're going to get one of 2 devices. One of the devices is called Walk with Path, which is an insole system with an app and a little dashboard where you can look at your foot pressures and monitor them for yourself. And the second one is a system called Sensoria, which is a sock-based monitoring system that has a little device, maybe a couple of centimeters square, that clips onto the side of your leg. And again, it just works on your mobile phone as a heat map for pressure and can provide information. So we're going to let people use these 2 devices for 3 weeks. And we're not really interested in comparing the devices. We want to expose people to see what their experiences are in a very natural setting, to really begin to learn how they will interact with these systems and what decisions they might make, and therefore what behaviour they might present with. So it's a mixed method study, so there's some quantitative data, but the really important data is entirely qualitative. It's entirely based on interviews. And so we'll be asking them things. Some of these methods come from a human behaviour and psychology background. So we're talking about performance expectancy. So do you find the insole equipment useful in managing your foot health? What are your opinions and experiences of that? Was it easy to use? Is it a good idea kind of conceptually? What do people who are influential in your life, your friends, your family, people who might have to support you with the device, what do they think about it and how do they interact with it? Do you feel like you're becoming more of a burden if you use that device because you need more help in order to use the device? Or in fact, is it reducing the burden you feel you place on a carer, on a partner? What anxiety do you have about it? People had concerns about, would they get electrocuted? What happens to my data? Am I being monitored? All those kind of psychological the psychological impact of simply having a different type of device with you every single day. And so we'll be able to capture and look at themes within all of those experiences that people have. The bit of work that I've never been involved in before, which I'm really enjoying changing the type of research that I do, is to think about how we make sense of what's in those interviews and how people describe their experiences, in order to then design an intervention which changes their decisions. And to do that, we're applying all that interview data to something called a COM-B model. A COM-B model is something which seeks to explain almost every human behaviour. So on the right-hand side, you've got a target behaviour. The target behaviour could be anything. If you're a parent, you can choose a target behaviour you would like your child to do more of or less of. In our case, it would be wear this pressure system more often. Or the target behaviour might be, if we were to send you an alert that you had high pressure, that you would respond in a particular way to that. So you define the target behaviour, and then there are essentially, the model suggests that there are 3 categories of factors which will determine whether you will exhibit that target behaviour. There's the capability factors, there's the opportunity, and there's the motivation. And we'll be able to take the information from the interviews and map them across the C, the O, and the M, so the capability, the opportunity, and the motivation factors. And what you can then do is you connect the distribution across the C, the O, and the M into what's called the behaviour change wheel. So for each of the C's, each of the O's, and each of the M's, there are a series of theory and evidence-based interventions that you can use to change people's behavior. So if we find that the issues are all about capability, then there are very specific interventions you can design to address those kind of barriers. If they're all about motivation, there are other types of interventions that you can design to influence someone's motivation. And so ultimately what we'll end up with is the wearable technologies, which do their job of generating pressure alerts, measuring pressure, providing the information to people. And then we'll have a behavioral intervention which helps people make sense of that information in ways that make sense to them and are more likely to address the barriers that they experience prior to them changing their behavior towards the target behavior that we would like. And so we'll be doing that in phase 2, which will be next year, which will have 60 people come into the trial. People will use one device for 3 weeks, and the device will be used alongside the behavioral intervention tool. And then we'll be collecting very similar data about experience, but also pressure data, to see whether their interaction and their response to the pressure alerts and pressure information is kind of different. And so one of the key bits of information will be, if I was to send a high pressure alert to a patient, what is the time lag between that alert arriving with them and them doing something about it? Is it seconds? Is it minutes? Is it hours? Is it days? Is it not at all? What is that window? And what happens in that window? What are they thinking? What are they processing? What are the barriers they're experiencing to them responding to that? It will be interesting to see whether you're able to set the pressure alerts at different thresholds. So earlier I talked about 200 kilopascals, for example, as a possible pressure threshold. If the threshold's too low, you'll be constantly getting alerts, and probably you'll start to ignore them. If it's too high, you might not get enough alerts, and you might forget about the system and not trust it anymore. So the thresholds have to be at the right kind of level, because people will be developing a relationship with it, as we all do with our phones, like it or love it. So that interaction is really important. There's also the opportunity for people to learn about the relationship between pressure risk and their behavior. So let's say that I realize that every time I go up a set of stairs, I get a high pressure alert. After a while, I will make that association for myself. So even when I'm not wearing the system, I will still remember going upstairs gives me high pressures. I might use the lift more often. So there might be a carryover learning effect in some of these cases. And we'd really want to sort of unpick what's going on in that decision making, in that window when people are beginning to make decisions about their physical activity, their behavior in response to those alerts. And then one of the key questions is, do the effect in terms of reducing pressure, reducing ulcer risk, does it differ between different technologies? And is that really about the relationship you have with that technology, or is it about the quality of that technology, the ability of that technology to measure pressure in the way you think is important? And 5 years ago, I would have said it's probably about the quality of the pressure measurement. And now I'm thinking it's probably got nothing to do with that. It's all about the relationship between that person and the device that they're using. So to just bring us back to where I started, I want you to take away that phrase, behavioral biomechanics. It might be a new bit of terminology, but it's that blending of the relationship between the person and their choices, decisions, and behaviors, and ultimately the biomechanical consequences for their body and for their feet. So do talk about pressure, do think about pressure. Biomechanics is important. I remember it comes in many forms, and we can get very confident because we can measure lots of pressure, but it's only one of the 3 forces that's applied, and we know the other 2 are really important, and we're not very good at measuring them. Pressure comes from decisions that people make and behaviors. That's the only source of pressure. So everything you like can be boiled down to decisions and behaviors. So I would invite us to think that we can change people's behaviors and therefore reduce pressures. Someone even said to me, is it like a behavioral orthotic? Because you're changing the forces through behavior. And so maybe behavioral orthotic is an important bit of language. But let's also recognize what we don't know, because we don't know how it is that behavior that we can influence behavior to influence pressure. And we don't know how to optimize that for different people. We all will have a very different relationship with a monitoring device like a phone or something else. So what makes you respond to a pressure alert and somebody else respond to a pressure alert, particularly if your levels of digital literacy, your social economic status, your race, ethnicity, etc., all of these factors will impact on your ability to change your behavior. And we certainly don't understand the nuances of all of those things. All of that is exciting for me because the last two words are, it means we need to do more research, which keeps me in a job and keeps me really interested. And I hope you've found that interesting as we stretch the conversation about what we can do with feet affected by diabetes. Thank you.
Very inspiring talk. As usual, this is an inspirational speaker. Do we have any questions from the floor? Yeah.
Any questions
Hello.
here?
Actually, I have heard about this, the research from LinkedIn. I have found it like 2 months ago. So actually, I also already write to Dr. Sumor.
Okay.
Yes.
Yeah, okay. Excellent.
So I have heard that you have selection of 4 items to this tool shock, and then to this the insole. Is that
Yep.
correct? So is it any reason why you choose a certain brand or certain product for this research?
That's a really good question. So we wanted to try out 4 different devices. And some of the context for that is you don't, you need different devices will all do things very slightly differently. Just as an Apple does it differently than Android and Samsung versus something else. So in order to explore people's experiences, you want to expose them to as diverse a set of experiences as possible, and that means giving them as diverse a set of technologies as possible. So we would have liked to have used 4. In the UK, and the way the funding system works, is there's a real push for ultimately how would your research have an impact. And so if, for example, a technology doesn't have appropriate regulatory approval and is not in the UK market and can't be used in the UK, then why would you evaluate it in the UK is part of what we heard. And some of the issues are around cost of some devices. So we started thinking about 4, and at the moment we're talking about 2, and we would still like to reintroduce 1 more. We chose socks and insoles deliberately because they're quite different by design, and they're already presenting different challenges for different people. But I think it would be nice to put one back in. There are lots of really pragmatic reasons, difficulties. So one of them, very, very practical issue is a lot of these technology companies are really small. They're very new to market. They're not big companies. They're not used to being involved in research. They don't give discounts. They can't produce the devices fast enough that you want them. So there's just some really practical things that are necessary. I'll shut up in 1 second, but we asked for a lot more money to do a big clinical trial, and what we got told was you're not ready because you haven't worked enough with the technology partners. The technologies may be fine, but you need to stress test them, because if they can't supply them, or they're so small they're just going to close as a company, don't do that yet. So we've been told to wait and do this sort of research first.
Actually, if you don't mind, second question. Anyone use sock for 3 weeks? Is it difficult? It's like people sacrifice mainly for scientist purpose.
Yeah. So there's these are, you sound like some of the participants. So firstly, the sock is washable.
Okay.
And also you can supply several pairs of the socks.
Oh, okay.
But that then becomes a cost issue.
So the central part is removable and so on.
The central part is like a fifth of that. And you can wipe that down and clean it on with a cloth, and that just goes on the side of the sock. But the sock itself you can wash.
Okay, is there any chance that if they by accidentally put it or like wrongly or in the different position that can cause the result? No?
Not in the position it's in, no.
Okay.
But these are exactly the kind of issues we're exploring with people. So the other one, for example, is about how to charge any of these devices. Some people are very worried about electricity costs. They're worried about something going on fire during the night. You know, so there are all sorts of really, really pragmatic challenges to using these devices. It all sounds wonderful in theory, but
Yeah, so maybe we have someone from the other theater.
Yes, we do.
Hi, Professor Nestor Lee Rogers here from Texas. First, I applaud your work and helping empower patients to be a partner in their care. And you know, I'm a believer that we use the term non-compliance too much. You know, patients are not really non-compliant. They'll just never do what they don't understand. And so we have to spend more time understanding and making them a partner in their care. My question is, you know, I'm not really convinced that continuous pressure monitoring makes a difference in the prevention of ulcers. I do believe in continuous temperature monitoring as a marker of inflammation, and I could see where pressure measurement at, you know, maybe once a year, you see the high pressure areas, you know to offload those areas. But a person's pressure changes throughout the entire day, you know, when they're walking. And so how do you know, what are your thoughts on that?
really good. So that, I think, is one of the questions we're trying to almost answer. I'm looking over there, there's no one there. So to give you an example, in Neil's previous work, one of the, where you come from? In Neil's previous work, one of the activities that generated a lot of high pressure alerts was driving. It wasn't walking, it wasn't standing, it was driving. So we don't yet know which activities are generating the high pressures. And I have a sneaking suspicion that once people have learnt about the relationship between the way they live their lives, the choices they make, and the pressure alerts, that they may not need continuous monitoring. It might be a fairly expensive, fairly medium-term education tool. And then once they've got the knowledge and they've made sense of it for themselves, they may not need constant reminding, because probably we have patterns in our lives that give us certain pressure alerts at certain moments. But those are almost the hypotheses that we're trying to explore, I think.
Anyone else from this theater?
Yes, we have one here. I'm doing the translation. Is there a technology that combines a pressure reduction saw with a sock that transmits the information to the patients? Do you want me to repeat?
Yes, could you repeat it slowly, please?
Is there a technology that combines a pressure reduction saw with a sock that transmits the information to the patients?
For the sock. So the sock technology does communicate the data from the sock to an app or to a dashboard. I think one of the problems at the moment is that being technology companies, people are very keen to give you as much data as possible, but probably 99% of the value in the data is in 1% of the data. And so we don't yet know what to show people. Is it a traffic light system and an alert, which is very simple and very small and very cheap to transmit? Transmitting large amounts of pressure data is energy hungry, data hungry, etc., etc. So, yeah.
Okay. So before we bring this, just a little comment, because you're talking a lot about behavioral change. And diabetes, the management of diabetes is really a lot about behavioral change. Yep. So if I have diabetes and I know that, I don't know, doing exercise is good for me, I know it, but doesn't mean that I'll do it.
Yep.
So those would be challenges.
Absolutely. So in another piece of work, we're looking at, we're interviewing people about what they experience the barriers to be in taking up physical activity. And then you map it against the COM-B model, and then you can link that to interventions that you need. And one of the most interesting one of the most interesting things so far about that is it's drilling down to the quality of the conversation you have with the person who's in front of you. And people don't want that conversation with a health professional because a health professional is educated and is holier than thou. What they want is a conversation with someone who looks and sounds just like them. And they don't want a health conversation. They want a social conversation. They'll do it if it's about socializing, about joining a club, doing an activity they enjoy. If it's about their health, they feel unwell. And if it's about exercise, it feels like you need to be mad about health or be in a gym or some other thing that's very off-putting for people. Yeah.
Anyway, thank you very much.
Okay,
I think otherwise we continue talking and talking.
Thank you.
Thank you.
Thank you. Is that for me? Thank you.
And I get to keep this.
It's my pleasure to give the floor to Professor Dr. Cynthia Formosa from University of Malta.
Thank you very much, Mika. First of all, I would like to thank the Pode board for all, congratulate you for this nice congress once again this year. And thank you for the invitation again. Pode is our family, as you know, so it's always a pleasure to come here. Well, Chris, although we're not seeing each other, I must say that my presentation is going to continue a bit on what you were saying. So although we haven't seen each other for about a year since last Pode, but it seems that Malta and the UK are working a lot on the same lines. So basically today, is it through this? No, sorry. I'm not a very technological person and I must have switched off everything. Sorry. Okay, so it's this side? Okay. I need to go back again. Okay, okay. Okay, so yes, today maybe even some of the things that I will be saying, I'll be maybe answering some of the questions with Professor Nestor was mentioning earlier before. So I will be talking about a wearable in-shoe temperature and pressure system to monitor the diabetic high-risk foot. So we all know these are the complications that we see in a diabetic foot. And obviously, we don't want our patients to come at this stage. We don't want to send our patients to Professor Rogers to do all his interventions and to cut off all the skin. As podiatrists, we want to take it a step before that. We want to try to save that high-risk foot. So I like to show this a lot, but I think it's very, very powerful. Again, what Professor Rogers was talking to us before, this again is work from Professor Armstrong in America, a paper that they published a few years ago. So we hear a lot of people talking about lung cancer and screening for lung cancer, breast cancer, and all these cancers, which is good. I'm not saying that these screening campaigns are not good. However, if we look at the 5-year mortality rate of major and minor amputations, we see that they are second leading after and third after lung cancer. So although we see a lot of campaigns on breast cancer, which I repeat is good, however, more people are dying with major and minor amputations than with breast cancers and any other form of cancers. Hence the importance of treating the diabetic foot. So we have published and we have conducted quite a lot of research at the University of Malta, in which we've shown the importance of measuring pressures and temperatures, as I will be showing you later on in the diabetic foot. As I said, this is what we want to prevent. And we do know, again, from the literature, that 50% of major amputations are preventable if we actually measure what we really need to measure. And yes, I agree again with Professor Nestor that also behavioral change is indeed very, very, very important together with all the measurements that we need to conduct. So this is all the technology that we have nowadays, okay, in our labs. That is our clinical biomechanics lab at the University of Malta. We have pressure systems, in-shoe systems, other technologies to measure gait analysis, okay. But obviously we do know that all this technology is very expensive. And as we heard also this morning, my colleague Alfred talking, that obviously to interpret all this data can be maybe sometimes very challenging for certain podiatrists and other healthcare professionals. So we thought of maybe trying to simplify all this technology so that more healthcare professionals, not only podiatrists, but other even healthcare professionals, would be able to maybe use, and even maybe patients, as Professor Nesta was saying, to use this technology and maybe alert themselves if there is a problem. As I said, we talk a lot about pressures, and even if we look at guidelines, the International Working Group, the guidelines, we talk a lot about pressures. Sometimes I think we tend to maybe sometimes forget even temperatures. And again, in another study which we conducted at the University of Malta, we did find a relationship, and we called it the thermopressure concept, where we know that when the pressure rises, the temperature rises, and vice versa. So maybe we shouldn't only be looking at pressures, but we also need to be looking at temperatures too when we are looking at the diabetic foot. So yes, we came up with innovative technology, low-cost technology, easy to use, allowing for monitoring of patient, their gait, their temperatures. As we heard also in the previous talk, not only inside our clinics when patients come to our clinics, not only maybe when we are doing research in our labs, we need to know what's happening out there in the street, okay? Because obviously a person needs to walk. We walk throughout the day, not only when they come to us and we just ask them to do a couple of steps. So in their home environment, sports environment. So it is very important that we know this different, and we gather this different type of data to understand better what is happening with regards to pressures and temperatures in the foot and in the shoe. So we developed this technology with a single sensor in-shoe pressure and temperature monitoring device. I must say, I must acknowledge this is the work from one of my PhD. Today I can say graduates, not student, because she graduated a few days ago. So this is a full-time PhD research, which we conducted at the University of Malta, where, as I said, we developed this technology. We validated it both dynamically and also statically, and this is all published. So those of you who would like to read more, this is all published data. So, but does it work? And this is the most important thing. So we conducted a clinical trial where we included 88 patients living with type 2 diabetes who had a past history of plantar ulceration. These patients also had prescribed orthoses from our hospital. Again, now maybe one thing which I don't know what maybe in your countries, but at least in my country, we prescribe high-risk patients with foot orthoses, but we never check whether we are actually getting the 30% reduction which Professor Nesta was talking about, and which is stated in the guidelines. We never check whether this is actually happening when we are giving patients the orthoses. And I can tell you that from our trial, when we tested, we checked the pressures for 44 of our patients, there were orthotics which we needed to modify because they were not actually reducing the pressure as we were thinking. So to come back to our study, we had, as I said, 88 patients living with type 2 diabetes. They had orthoses. Patients were divided into two groups. We had 44 patients who received our standard care, so it's the normal care they receive in our hospitals, podiatry care, given their orthoses, and they visit us every 2 or 3 months as need be. And then we had our 44 cases whom we tested their pressures and temperatures on a regular basis, whilst also receiving their standard care. We also, as I said, if their orthotics needed any modifications, we modified. We checked them every 4 months for a period of 1 year. And does it work? Well, if you look at this chart, I think this chart talks for itself. I know it's a bit busy, but basically these are all our patients, the control group and the experimental group. So in short, the control group who were not tested and checked for their pressures and temperatures. At the end of the study, we ended up with 4 amputations and about 5, 6, 7 active ulcerations, okay, within a year. However, if you look at the experimental group, which we followed every 4 months, checked their orthotics, if they needed correction, we did so, we only ended up with 2 active ulcerations. So I think, as I said, this study speaks for itself, and this is a representation of our results. So yes, if we look at the guidelines, as I said, technologies, innovative technologies are not included to date. A lot of work is being done. We can see with our colleagues, both in the UK, as I said, in Malta and in other countries. However, unfortunately, if we look at screening guidelines, they still recommend that, as I said, we need to test for neuropathy, test for PAD. However, there is very, very little mention of what guidelines on what a clinician should do with regards to biomechanical and temperature measurements in the foot. So we recommend that potential guidelines should compile and make use of existing experimental evidence rather than maybe anecdotal and opinion-based evidence, which sometimes, unfortunately, happens when you read these guidelines, and as stated, and again, in one of our publications, which was published a few years ago. So medical and smart technology, the role in healthcare, I think this is the future. This is where everyone is going. I mean, I go to conferences across Europe and everybody's talking about this today. So there has been a lot of technological and scientific progress relating to the assessment and intervention of foot deformities, including these wearable insoles and advanced materials with an option of 3D printing, which also should be reflected, I feel, in diabetic guidelines, food guidelines. However, obviously, such changes in guideline can only happen once we have enough and acceptable evidence, hence why, again, as Professor Nestor said, we need to conduct more and more research so that we can, obviously, our guidelines could really be evidence-based. And again, this is one of our latest papers, which we have published in the International Journal of Lower Extremity Wounds, where we actually advocate that we say that it is time to turn the tide for diabetic foot screening. We've been doing the same screening for a number of years. Amputations are not on the decrease. We can say that amputations are still there, still increasing. So we must be doing something wrong, I believe, somewhere. And I think the time has come that we need to look into all these artificial intelligence and smart technologies to try to find a solution for this very big problem, which unfortunately hits a lot of people and brings about a lot of misery and poor quality of life to our clients. Thank you very much for your attention.
Are there any questions in the audience? No? In the other amphitheater?
Yeah, seems like we have a question here.
Thank you, Cynthia. It's Chris Nestor. I'm not going to walk across the auditorium. So yeah, we're singing from the same hymn sheet, aren't we? I guess I've got 2 questions. You measured temperature and pressure, and I wonder whether you think one was ultimately more important than the other? And the second is, what precisely did you do differently because of a change in temperature, because of a change in pressure? And was any of that with the patient, or was it just about devices?
As such, when we revisited the patient every 4 months, with regards to temperature, we didn't do much. With regards to pressures, yes, as I said, these patients were all wearing the orthotics which are given by our hospital. So we checked them and we reduced them to an acceptable offloading pressure, so that obviously they will do what exactly they need to do. So really in the study, although we did measure and we did check for temperature, and we did find a correlation that when the pressure seemed to go up, the temperature also went up. However, we didn't control for that during the 1-year trial. We only controlled for a decrease in the pressures.
Okay. Any more questions? Perhaps something that I might add as well. One of the surprising facts was that half of the devices that were supplied by the hospital needed readjustment because they weren't doing what they were supposed to do. Really. Okay. So no more questions from this theater here.
There's a question up there.
Between pressure of temperature, is it the best? Est-ce qu'il y a un meilleur entre les deux? Yeah.
Which one is the best, temperature or pressure?
Well, I think that's a very difficult. I think, as I said, we did quite a number of research. We did find a correlation between both. So it seems that one goes up, the other goes up. So I think we need to monitor for both. So most probably when there are higher pressures, it means that there are higher temperatures in the foot and vice versa. We've got quite a number of publications where we've tested this concept a number of times, and we also always found the same results. So I think both are important for the high-risk foot.
Okay, thank you very much.
Thank you.
Okay. We'll come to the next presentation. So apologies if I don't pronounce this right. María Gámez Guijarro, okay, from Spain, who will talk to us about biologic treatments. Yeah, you can do that. Cheers.
Hello, I'm María Gámez. I'm a doctoral student of the University of Málaga. I'm going to try to make it short because this hours is difficult. We are so tired. I'm going to talk about the field of rheumatology, and the question of this study is, do biological treatment reduce foot pain and significantly improve the quality of life in patients with rheumatoid arthritis? I would like to clarify what is the rheumatoid arthritis. It's a chronic, inflammatory, autoimmune, and degenerative disease that produces joint pain and stiffness, producing gait disturbance, self-care deficit, increased fatigue, functional impairment, concluding in a decrease of quality of life. This disease affects in 90% of the patients in the foot, producing deformities in different joints. The most frequent are metatarsophalangeal and proximal interphalangeal joints. The prevalence in the forefoot is 90% with deformities such as hallux abductus valgus or clautus. In the midfoot, we have 40 to 60% with a descent of the longitudinal arch, and in the hindfoot are a 30 to 60% of prevalence producing valgus deviation. The prevalence of rheumatoid arthritis is 0.5 to 1%, having a predisposition in women compared to men and having a predisposition in persons with genetic components. The etiopathogenesis of this disease is divided in two phases. Into preclinical phase, there are a genetic predisposition that together with bad habits, such as unhealthy habits or smoking, produce an autoimmune response without symptoms, leading to the clinical phase where we find joint deformities, pain, and different symptoms. In this phase, we need more tests to diagnose this disease. The diagnosis of the rheumatoid arthritis is so difficult because it's a heterogeneous disease. The diagnosis is carried out with criteria standardized by American College of Rheumatology and European List Against Rheumatism, because these 7 criteria created by American College of Rheumatology were not enough. We can evaluate this disease in 4 levels: remission, low activity, moderate activity, and high activity, with which it allows us to adjust the treatment that the patient requires at all times. In this table, we can see different methods of evaluation. We can highlight the DAS-28. We can highlight the DAS-28 because it's considered the gold standard. And in this table, we have the radiological evaluation. But as we can see, the foot have little importance. Almost everything is about the hands. In this slide, we can see the treatment. There are 2 groups: the synthetic, intended for strict control of the inflammatory process, and the most common is the methotrexate, and the targeted or biological treatment to control of the autoimmune activity of the disease, reducing inflammation and halt joint destruction, producing low activity or remission, and short term. The methotrexate is the treatment of choice of American College of Rheumatology and European Leagues Against Rheumatism. And if it doesn't work, we need to use the stronger treatment of corticoid. In this table, we can see some examples of the different treatments, synthetic and biological, and if we combine these two types of treatments, we can reduce in 50% the joint destruction. But we have to keep in mind that all the treatments have side effects. So, do biological treatments provide clinical benefits for the foot, improve its functional status, prevent structural joint damage? In this graph, we can say a hypothetical case. The red line is without biological treatment, where the osteoarticular destruction is in a short period of time. The purple line with synthetic treatments, we have a longer period of time, and in the orange line with biological treatments, we have a longer period of time for the osteoarticular deterioration. So our hypothesis is that biological treatments improve foot pain and quality of life. And the primary objective is to observe levels of pain, deformity, and quality of life related to the foot pain in patients with rheumatoid arthritis with or without biological treatment. There was data collection from April to August 2023 to August 2023 in the Rheumatology Department of Virgen de las Nieves University Hospital in Granada. We have a cohort of 234 patients from 2018, of which we select 103 patients with rheumatoid arthritis. In this table, we can see the inclusion and exclusion criteria. Some inclusion criteria are adults aged 18 and above meet the American College of Rheumatology and European List Against Rheumatism 2010 classification criteria, etc. And some of these exclusion criteria are having a surgery on the lower limb in the last 6 months or trauma in the lower limb in the last 6 months. The variables of this study were the age, gender, and the typical variables, and some questionnaires such as foot pain assessment by visual analog scale, quality of life with foot function index, DAS-28, foot posture index, Manchester scale for allus valgus, and Nijmegen classification. And another variable very important was the anthropometry. The anthropometry was made with McPoyle platform. McPoyle platform is a platform that produces standardization and repetition on different foot lengths with minimal margin of error. In this photograph, we can see the different part of this McPoyle platform. In the first total, we can see the total foot length. In the second, first metatarsophalangeal joint, maximum height of longitudinal arch, and forefoot wide, midfoot wide, and hindfoot wide. Regarding the results, the pain in foot function index increased from 2018 to 2023 with and without biological treatment, but with biological treatment, the difference is smaller. The disability in foot function index increased from 2018 to 2023 without biological treatments, and it decreased slightly from 2018 to 2023 with biological treatment. And the foot function index total increased from 2018 to 2023 with and without biological treatment, and with biological treatment, the difference is smaller. In anthropometry, from 2018 to 2023, the mean forefoot wide increases, the mean maximum height of the longitudinal arch increases, and the mean midfoot wide remains being the less affected. So, does foot functionality improve depending of the treatment? Does foot pain improve with one treatment or over another? Is foot deformity less with biological treatment? Also, pain is not correlated with the treatment. Foot deformity continues its progression independently of the treatment, and we think that it depends of the age of the patient, of the years of the evolution of the disease. We claiming that the combination of the three types of treatments produce improvement in foot functionality. Synthetic, like methotrexate, biological treatments, and corticoid. Talking about the study limitation, the long-term evolution of the disease interferes with the result obtained in the perception of the quality of life. So we need homogeneity of the study group in terms of disease progression and quality of life. And the most important thing is that not only foot pain alters the functionality and biomechanics of the foot, also the characteristics of the foot and the administered treatment produce foot pain. This is the most important bibliographical reference used in this communication, and it's all. Thank you very much.
Thank you very much. Do we have any questions from the floor? Anything from the other side?
No, there are no questions. Thank you.
No questions. Okay, thank you very much. Thank you. Hope your foot is okay. There are many podiatrists here.
I would like to invite Ms. Fernández from the University of Seville, who's going to be talking about percutaneous electrical stimulation as an alternative treatment on foot compressive nerve syndrome.
Okay, good afternoon. My name is Regife. I'm a master's student for the University of Seville. Firstly, I would like to thank the organization for giving me this opportunity. I'm going to present a literature review about the percutaneous electrical stimulation as an alternative treatment of foot compressive nerve syndromes. To begin with, it is worth mentioning that neuropathic pain is a chronic pain caused by a disease or injury to the somatosensory nervous system. This type of pain is present in nerve entrapment. It is defined as a prolonged compression on a peripheral nerve at any point along its course due to extrinsic or intrinsic mechanical forces. They pose a diagnostic challenge because they are uncommon due to the variability or etiologies and clinical manifestations, or a possible deficit in anatomical knowledge on the part of the clinician. Sometimes, conservative treatment proves not to be completely effective, so new techniques are sought to address this condition, such as neuromodulation, in this case with percutaneous electrical stimulation. The main objectives of this study was to assess the effectiveness on a percutaneous electrical stimulation technique in the treatment of neuropathic chronic pain caused by the most frequent nerve entrapment syndromes in the foot and ankle. The second objectives were show the most suitable parameters using percutaneous electrical stimulation therapy, or to demonstrate the efficiency of the PNS technique in reducing different types of pain and nerve entrapment syndromes in the body. Neurons are responsible for transmitting information through either electrical synapses, direct communication between both parts, or chemical synapses. It's a more common, recurring neurotransmitters for transmitting to produce inhibition or stimulation to the postsynaptic cell. There are different types of nerve fibers classified based on the diameter and conduction speed. A, delta, and C fibers stand out, aiding in the detection of various painful stimuli. Pain is an patient sensory and emotional experience related to actual or potential tissue damage described in terms of such damage. From the moment the body comes into contact with a handful of stimulus, a series of neurophysiological processes occur, responsible for transmitting the stimulus to the brain to produce pain: transduction, transmission, modulation, and perception. The most common nerve syndromes in the foot are tarsal tunnel syndrome, anterior tarsal tunnel syndrome, or a Baxter neuropathy. The symptoms can be negative, ascents on decreasing sensibility, or positive, like spontaneous pain, paresthesia, or allolinea, for example. The neuromodulation techniques can act by stimulating the CNS or the PNS transcutaneously by TENS, peripheral by PNS, or by inserting a needle with ultrasound guidance in a peripheral nerve at some point along its course, or a muscle with the aim of reducing chronic or neuropathic pain, restoring the natural function of the nervous system, or producing an improvement in neuromuscular function, muscular recruitment patterns, and motor control. Currently, the detailed mechanisms of action are not fully understood, so it's released various theories to have been studied so far, like gate control theory, endorphin release theory, or activating the descending pathway with are diminished in neuropathic pain situations. Articles have been collected and selected during the month of January, February, and March 2023 through the databases PubMed, Dialnet, Scopus, and ScienceDirect, in addition to using other support databases such as Google Scholar or the Health Library of University of Seville for the theoretical framework. Keywords were combined with each other using the violence operators and an OR. The articles included were published in the last 16 years, except for 4 previous articles with high scientific relevance, performed on human or animals, or bibliography review, systematic or meta-analysis, randomized or not randomized clinical trials, observational studies, or case report. Finally, a total of 51 articles were included. After eliminating articles based on a tail, abstract, or duplicates, a total of 18 articles were reviewed involving 622 volunteers. Regarding the efficacy of the therapy from the treatment on musculoskeletal pain, the authors conclude that decreased pain intensity, reduced medication intake, produced substitute improvement, improved muscular resistance and balance, improved functionality or disability, and it's more effective combined. However, the results were only evaluated in the short term. In chronic low back pain, the author concludes that therapy reduces pain, reduces medication intake, improves physical function, and depends is better than tense or exercise. However, the duration of the analgesic effect was different in each study. In chronic neuropathic pain, the authors conclude that therapy reduces pain and is effective and safe. Also, they found that the analgesic capacity was short-term. In postoperative pain, the author concludes that therapy reduces pain and reduces medication intake. However, we must not forget the enduring complication involving in implanting a device. Among all the authors who reflected the parameters, they have been classified in those who alternative frequencies, those who use low frequencies and high frequencies. The frequencies reaching is a range between 2 Hz and 100 Hz to 20-30 minutes. The low frequency is a range between 2 Hz and 10 Hz to 16 to 30 minutes, highlighting the one that use only 1.5 minutes. The high frequency, the author sent 101 Hz. Also, they varied greatly over time. But try use parameters based on long-term depression and long-term potentiation protocols. The LTD is producing analgesia, causing a pre- and post-synaptic depression of the nociceptive pathways, the fibers, and activating the endogenous descending pathways, used especially in patients with chronic pain. The LTP, it causes analgesia by stimulating the A-beta fibers that do not transmit pain to inhibit nociceptive contusion of the C fibers to carry control. Additionally, it also activates the endogenous descending pathway. Intermittent impulse breaks are important because continuous stimulation will lead to depression of the A-beta fibers. Regarding the efficacy of the technique in reducing pain caused by nerve entrapment syndromes, two authors applied peripheral stimulation using an implanting device of various nerve entrapment pathologies. They conclude that the technique reduces pain, increases mobility, and improves quality of life. Furthermore, the analgesia was sustained after 1 year. Three authors used pain therapy in femoral nerve, ulnar nerve, and radial nerve entrapment syndromes, where they obtained an improvement in function, range of motion, and pain, with one of them achieving complete resolution of symptoms at 5-6 months. As I was doing this work, I realized that the articles I found were scarce and with little evidence, and as well not finding those that address nerve entrapment syndromes in the foot and ankle. That's why I started researching and exchanging information and experience with some physiotherapy and podiatry professionals who regularly use this technique as a treatment for nerve entrapment syndromes. As you can see in this photo, the treatment for tarsal tunnel syndrome. It was able to observe both in person and through the clinical cases that both meet the high level of patient satisfaction in terms of pain reduction and improvement of functionality. These results were evaluated based on experience of HS professionals, so I hope in the near future to carry out this study with the appropriate methodology and designed to demonstrate it. The first conclusion was there are difficulties in demonstrating the effectiveness of the technique in nerve entrapment syndromes in the foot and ankle. Also, there are evidence for those occurring in other parts of the body. The technique demonstrated ineffectiveness in the short term regarding the reduction of the musculoskeletal, neuropathic, or postoperative pain as medication intake. the established authors use different action protocols with the majority alternating high although frequencies in an interval of 20-30 minutes. And that is all. It is a pleasure to present my literature review, and thank you very much.
Thank you. Are there any questions in the audience? No? Are there any questions in the other amphitheater?
Do we have any other questions from here? Right. Seems not.
Okay, thank you very much.
Thank you. So, last but not least, Danique van Gulick from the Netherlands, a prediction model for falls in community dwelling older adults in podiatry services. Thank you very much. So, yeah, to go advance forward that one, okay?
Can you hear me? Okay, thank you. Good afternoon, everyone. My name is Danique van Gulick from the Netherlands. I'm podiatrist and clinical epidemiologist at RondOm Podotherapeuten and PhD candidate. I would like to tell you something about our study, development and validation of a clinical prediction model to predict falls in a community dwelling elderly visiting the podiatrist. First, I want to start with a quotation of Marshall Levy. He is professor at the University of Amsterdam. And he said, falls in elderly people, an epidemic where nobody talks about. Fall prevention, to deserve more attention. It's not the most sexy subject, but it has the potential to yield enormously more health benefits than complicated operations and expensive medicines. And I want to show you why. Falls are an increasing health problem in the growing elderly population. 1 out of 3 people fall each year and increased with age. Here you can see the numbers. In this slide, I show you a Dutch infographic with some numbers. And firstly, here you see the numbers who injured after a fall, 7,680 people. 36,700 people are admitted to the hospital. 30,300 people are admitted to a nursing home. And 5,012 died due to a fall. In this slide, you see the prognosis of falls in the next few years. So currently, in 2020, these are the Dutch rates. 100,000 people were visiting the emerging department. In 2040, it will increase to 200,000. Oh, they can see me in the other room. Sorry. And there are some reasons for that can be mentioned. The increasing age at the community. There are more people 85 years or older, and people stay longer at home. In this slide, you see the cost. In 2020, the costs were 1.1 billion, and it is expected that it increase in the next years. So in conclusion, it's necessary that we do something about it. So, as podiatrists, we look at what we know already, and we know that age is associated with foot problems. And older people are in 20 to 45% affected by foot problems. Here you see some studies that show the association between them. So increased age is also increased with soft tissue stiffness, with decreased range of motion, with decreased muscle strength, more pronated foot posture, less efficient propulsion. And another study shows that it is associated with pes planus posture, hammer toes, and overlapping toes. So we know that that's the association, but we know more about this. So we know there's an association between ACE and foot problems, but there's also an association between foot problems and falls in the last years. Let's take a closer look at this. Since 1988, TINITY already shows that there's a relation between foot problems and falls. In the next years, there came more and more evidence about this relationship. And here you see some factors which are associated with falls. So, decreased ankle flexibility, hallux valgus deformity, decreased tactile sensitivity, foot pain, decreased plantar flexion strength, and another study described that it was the lesser toes and the hallux which was associated, lesser toe deformity, foot pain from fasciitis plantaris, and foot posture. And there is a systematic review in 2018, and they conclude that there's a relation between hallux valgus deformity, foot pain, lesser toe deformity. That are the most important factors. Okay, so you can see the amount of papers is increased the last years about foot and falls. But the first question is, okay, we know what there's an association and we know there's emerging evidence, but what do we have to do now with this information? So let's take a closer look to the pyramid of evidence, and then we take the first step, clinical practice guidelines. If we take a closer look to the American, the British, and the Dutch guidelines, they said every healthcare provider have to screen each person 60 years or older and ask, have you been fallen the last year? Also, they said falls prevention consists of 3 steps. The first step, who's at risk for falling? Case identification. The second step, multifactorial fall risk assessment. Why is the person at risk for falling? And the last step, what do we do in persons who are at risk for falling? So the fall prevention interventions. Our study with the development and validation of a prediction model starts with step 1. So identifying which people are at risk for falling. How can we do that? We can use a fall risk instrument. However, the problem, there's no golden standard, and the accuracy is low, and the implementation is poor in podiatry practice. The solution, maybe we can develop an instrument who's tailored to the population who visits a podiatrist, such as patients with foot problems or with diabetic. Let's take a closer look at the method of the study. We conducted a prospective study and included older adults, 65 years and older. We had a study sample of 425 people, and we collect baseline data at 135 podiatry practices, and the following baseline data was collected. The demographics, 5 general-related variables, 7 food-related variables, and 2 function-related variables. After baseline measurements, we followed the patient for 12 months using a calendar. Yes, here it is. And we had telephone contact with every patient, every quarter. After that, we did some statistical analysis, but I want to show you the practical things you can take home and you do tomorrow in practice. So we go to the further one. Here are the results from the univariable analysis, and here you also can see which variables we have included in our study. So the general fall risk variables, fall history in the previous year, fear of falling, unsteady while standing and walking, use of a walking aid, and use of psychoactive medication. The food-related variables we included: ankle dorsiflexion, range of motion, tactile sensitivity of the first MTP joint, toe deformity of the hallux valgus and the lesser toes, foot pain, and toe plantar flexor strength of the hallux and the lesser toes. And the last two were the function-related predictors, gait speed and a balance parameter. Here you can see the two groups, the fallers and the non-fallers. And after that, you can see the p-value, which one is statistically significant between the groups. There are a few factors: fall history, unsteady while standing, walking, use of a walking aid, tactile sensitivity of the first MTP joints, toe plantar flexor strength of the hallux and the lesser toes, and at last, gait speeds. Okay, so now we know there is an association, but we already have seen before that the association was already known. So we have done another analysis once we want to know which combination is the best one to predict a fall in practice. And that analysis results in a combination of 4 factors: fall history in the previous year, unsteady while standing and walking, lesser toe plantar flexor strength, and gait speed. Here you see the coefficients of the development cohort, and after shrinkage, you can see the internal validation. You can use an equation to calculate fall risk in podiatry practice. However, it's more practical to use a nomogram. And how you can use a nomogram is as follows. I show an example. So there's a patient in practice, and he said to you, yes, I fall in the last year. So he gets a score 1 for that variable, which corresponds with 54 points. The patient said, no, I'm not unsteady, so there are 0 points for that predictor. The patient wasn't able to grip the card when removing. I think I have to explain how you test plantar flexor strength. The patient is seated with the knees and the hips in 90 degrees, and you ask the patient to grip a business card, and you try to remove the card. And if the card is easily removed, then the test is positive, and then you can see there's number 1 on the score, which results in 60 points. The last one, we ask patients to walk 6 meters, and we measure how many time. And this person needed 6 seconds, and therefore they get 70 points. In total, this patient gets 87 points, which corresponds with an increased fall risk of 32%. And we have determined that when the fall risk is 30% or higher, then the patient is at risk for falling. So this example, this patient is at risk for falling. So in conclusion, in clinical practice, case identification in older adults, 65 years or older, each year have to be asked, are you fall in the last year? Do you feel unsteady while standing and walking? How many time do you need to walk 6 meters? And the patient can use their usual pace and wear their own footwear. And the last one, can the patients grip the card, the paper grip test, to measure the muscle strength? This work is published in 2022, but always research has the recommendation to further investigate something. So this is exactly here what's done. For this study, it is necessary to, again, measure the performance of the model in a new study, the external validation. That's always necessary for a prediction model before you implement in practice. So we have started a new study now, and the study is called Explore, the external validation of a prediction model for falls in community dwelling older adults in podiatry practices. And this study has completely the same method as the original study, the development cohort, but with 300 patients in multiple podiatry practices. And now we only collect the variables of the model, so the two general fall risk variables, one food-related variable, that's the paper grip test, and one function-related variable. And after that, again, we followed the patients for 12 months. This study is started in 2023, and I hope it will end up in 2025. But yeah, we are dependent of the population. And after that, we do the descriptives, and again, predictive performance, and we made a comparison with the current guidelines. So, that's the last one. Falls are the epidemic of the past now, but not for the future, I hope. Do you have any questions?
Thank you for that extremely interesting, very
You're
interesting,
welcome.
which shows the importance of podiatry, after all.
Yeah.
It's a fresh outlook. Do we have any questions, please?
Here, on this side, is there any questions?
Danielle, that was really quite an impressive story to do the first piece of work and now to apply it, and really nice big sample sizes. So you've got 300 or 400 you're targeting or you've already found. How many practices are involved? And are you evaluating the experiences of the professionals? How do they feel about the process? What support or training do they need? Yeah. So that it could be scaled up to even more practices in the future?
Yes, that's exactly what we do now. Thank you for the question. Yeah, currently there are 8 practices. Yes, currently 8, I think. And we see that the amount of inclusion is currently 70, I think. And we want to go to 300. So we need more practices. And this is currently directly, I don't know how to say it in English, a reflection how the implementation is working in clinical practice. So we learn a lot of it, and that's the reason why we try it in a lot of practices. Thank you.
Okay, thank you very much.
Thank you.
Thank you very much.
Thank you.
Wait. We have our...
So I invite the people in this amphi to move to the other one for the closing speech, because it will be there, so it will be nicer for you.
Yes, we're waiting for you. Thank you. So yes, I'm calling all the MPOD board, please. Joao, Javier, Mieke Francen, come with me.
Okay. And then I'll do Alfred, and then you take over for the practical things tonight. Do you have to say anything for tonight, or?
See what you want to get.
Okay. But I'll wait until they're here. So I'm gonna thank you first, then I'll do Alfred. You're gonna tell it, yeah. You could.
Para Cynthia, que está...
Go or wait for everyone? No. So in closing, we want to thank some people, and I want to start by thanking our board member Yves Lescure and his entire team here at the École Rockefeller for organizing an amazing conference, an amazing 3 days, and yet one to come. So very big thank yous for the outstanding organization. Let's wait. Thank you. Secondly, we want to express our gratitude to someone who has done a lot for our network and our organization. So please a warm applause for our former president, Alfred Gatz.
Alfred, a little present from all the Embody team and all the Rockefeller team to thank you for all you've done. Okay. You're like our father to all, so so thank you again. Okay, but it's not the only person we want to thank, because with Alfred there was a great vice president before, and I'm calling Mr. Gabriel Gijon to come, please, because we want to thank you too for all you've done for Embody family. Okay? If Alfred is my father, you are my brother in the notice, okay? I would like to thank you all to be there today. It was a big work for all the team, for Eleonore Perrin, we did the chairman of the Congress. She did all the organization. She was our chief actually during 6 months, and it's over now. You're not the chief anymore, okay? But she was the chief. She organized everything, and she was very well assisted by María Nicolas. We did a great job too. Please, you can applaud them, please. But there's so many people I want to thank about the organization, because we were a lot of people of Rockefeller. We are a great school with a great team. On all the stairs of this school, there's many people, very great, actually. That's all I can say. And I would like to thank everybody, Anne de Prantière. I would like to thank Cathy Bérangère. I would like to thank all the team, Céline, that made a great job. A special thank to, it was the last part, a special thank for Anthony and all the techniques that has been done today with Anthony. Thank you for the Europelec company to help us to make this happen. Thank you very much for your work today. Did I forget anybody? I would like to thank everybody, okay? It's simple. Thank you. I'm sorry if I forget someone. And a special thank again for all our students to be there today, and the big help they gave us to organize it well. So thank you very much. I already did it this morning, but I do it again. Thank you very much for all the students of Rockefeller. And thank you. And a big thank you to all the sponsors we had today. We had the chance to have a big team of sponsors, which allowed us to make that type of techniques and experience you have today with those screen and everything. So thank you to all the sponsors. Really, it's the beginning, I think, between the sponsors that were today and the Embody for now and the future. So it's a very amazing day. Thank you very much at all. I cannot talk anymore. and see you in Madrid next week. Not next week. You need to rest a little bit. So see you in Madrid next year. It's going to be amazing, I think. Okay. Something to say, Alfred?
Oh, okay. He's tired of talking, so he just don't give me the microphone. Otherwise, this will not end. So we get this evidence that Embody is a network of friends. And that is the first thing. It is friends. When you need something, you go to a friend. You don't go to a colleague, okay? So build up a network, especially for the students. build up a network from when you are students. You will find those friends in the network later on in your life. Okay, so I better stop.
Thank you very much. One last thing, we had the chance today to have two external guests of Empode, but now they're part of the family. I'd like to thank Lee Rogers for coming and support us. It was very great to have you both days. Thank you for everything. Thank you, being there. And thank you for the knowledge you bring with you, okay? And I'd like to, a special thank to Laurent Malissou, which made the presentation at the beginning of the afternoon, sorry. Thank you for everything. Now we can quit, okay? No.
No, two more things. We had two contests, along the day for the students. One for the poster and one for the sponsors. So for the sponsors, we have two winners because we have two people with the same amount of points. So the first winner is Emma Cellier, who already left. And the second winner is Hugo Clairon, sorry. So they are not here, but I will send them their gifts and the diploma. And for the poster, the winner is Astrid Barset. You can come. Congratulations. So you have, you can say. You have this diploma and you have also j'arrive plus à parler anglais. Comment on dit abonnement? A gift card, non, bon. From la revue du podologue, you will a subscription for 1 year. You will receive a few books from them too. And you will receive a gift card from the Empode. Okay. Thank you for everything. For those who are joining us tonight at the gala to the tour in city, do not forget your ID. It will be checked to go up in the tower. So don't forget it. Okay? Thank you.